Okay, folks, it's 5:03. We need to get going.
We're live.
Good evening, and welcome to the 2020 CUIMC Election Forum. I hope everybody is well. My name is Ross Fromer, and I am the Vice President for Government and Community Affairs and Associate Dean here at Columbia University Irving Medical Center. In a Pew Research study done earlier this year, over 2/3 of respondents said healthcare was a very important issue. We host this event as part of our civic engagement effort so that students, faculty, staff, community members, and friends can have the opportunity to learn and discuss important health policy issues and how the candidates would address them. This is the 5th time that the CUIMC Office of Government and Community Affairs has put on the Election Forum. But of course, this year's event is like none of the previous ones. By now, we all have experience with virtual events, and we think we have everything set and ready to go. But if we do experience technical difficulties, I hope you will bear with us. Tonight's event is being recorded and will be available on YouTube and other social media channels shortly. If you have any comments about the forum or would like more information about the CUIMC Office of Government and Community Affairs, please visit our website at www.gca.cumc.columbia.edu. You can also like us on Facebook and follow us on Twitter. Before we get started, I should note that Columbia University is a not-for-profit and as such does not endorse or oppose any candidate or political party. Our moderator will introduce everybody shortly and get into more detail about how the program will flow. But we have a wonderful panel of health policy experts with us this evening. They will each make a few opening remarks, but most of the time will be for questions and answers. And we have a group of students from all 4 CUIMC schools who will kick off the discussion before we get to the questions from the general audience. If you have questions, please use the Q&A function on Zoom. For those of you on YouTube, we will be monitoring the comments section and can relay any questions to the moderator. The CUIMC Election Forum is made possible with the generous support of Dr. Marc Grodman, a 1977 graduate of the Columbia University Vagelos College of Physicians and Surgeons. Marc, would you like to say a couple of words?
Sure. Am I on there? Okay.
Yeah.
Ross, thank you very much. I want to thank you for being able to put all of this together. I just want to say a few comments to the students that are here from whatever schools, whether it be dental, public health, pursuing PhD programs, or the medical school. These are unusual, different times than what we've ever experienced. But the one thing that we've seen is that health professionals over the course of these last 7 months have had impacts on all of us that may have been unimaginable in any other time. Ross was right. I graduated Columbia in 1977, the medical school, and I've been on staff since 1983. At the same time that I spent 30 years as a public company CEO, started one company, starting another, and spent times with besides business, with legal issues, policy issues. And the one thing that I've really learned over the time is that one, the training in health as a health professional, as a clinician, was always the most important basis of everything I ever did. More importantly, when I sold the first company 4 years ago, what I realized is that in all likelihood, there is better no use case for the interdisciplinary manner in which health professionals can make an impact other than global health security and pandemic preparedness, all of which has made everything that's happened in the last 7 months. Because the solutions, quite frankly, demand interdisciplinary approaches, not only from the schools that are represented here, but by business and law and policy and engineering. So what the solutions demand is that interdisciplinary approach. So this year is different than any other. And the one comment that I wanted to make to the students is, as you've seen, impacts will come in a variety of ways, some traditional, some not. And you can make that impact. But just wanting it is not going to do it. Just the training is not going to do it. Training will not push you there. You need to push your training to give you the skills and the comfort with all disciplines necessary to make an impact in many ways that will affect people. Anyway, Ross, thank you very much for doing this. I look forward to hearing the forum.
Thank you, Mark. I should note for those of you interested in tweeting along, our hashtags tonight are hashtag CUIMC Election Forum and hashtag CUIMC Votes. It is now my pleasure to introduce Dr. Anil Rustagi, the Interim Vice President, Executive Vice President, and Dean of the Faculties of Health and Sciences and Medicine here at CUIMC. Dr. Rustagi, would you like to say a couple of words?
Yeah, thanks, Ross, and thank you, Mark, for sponsoring this wonderful effort, and Ross for coordinating everything. It's really obviously a volatile time in our national politics, but that indicates even more so than ever that we not lose sight of the important issues in science, medicine, and healthcare. And I welcome all the participants on this forum, as well as our expert panelists, and look forward to a great conversation this evening. Thank you, Ross.
Thank you, Anil. Okay, so let's get started. Our moderator tonight, Sri Srinivasan, is the former Chief Digital Officer at Columbia University and the current CEO of Digimentors. He's also a visiting professor at the Stony Brook University School of Journalism. Sri, I think this is the fourth time, I believe, that you have moderated the CUIMC Election Forum, and we're really glad that you're back with us tonight. Again, thank you for joining us, and Sri, take it away.
Hello, Ross, and hello, everybody. Thank you so much for having me back. I will always be a Columbia University graduate, and I have Columbia in my blood, so delighted to be here and to talk specifically about healthcare policy. This is the third time we've done this. In previous sessions, we've had fabulous speakers, and we have them again. One of our previous fabulous speakers went on to become Surgeon General, so no pressure on our speakers tonight. We are going to have our experts who will be joining us, our professional experts, and then our students are going to ask questions, and we're going to give all of you a chance to ask questions as well. So please get your questions ready. If you're on YouTube, you can be posting there as well, and we want to hear from you for sure. So let me tell you a little bit about each of our speakers, and then they will make some remarks, and then the students will ask them questions. So let's get started. And please remember to use the hashtags and also to follow at Columbia Med. So first, let me tell you about Sheila Burke, who is with us. She serves as Senior Public Policy Advisor at Baker Donelson in Washington, D.C., and Chair of Government Affairs and Public Policy. She's adjunct lecturer in public policy at the school for many years. She has a long history in the political realm, including having been chief of staff to former Senate Majority Leader Bob Dole. Hi, Sheila. And we also have Dr. Donna Lind, who is with us, Center, and the CEO of Columbia Doctors, an 1,800-member faculty practice organization. She was, until 2019, Colorado's 49th Lieutenant Governor and Chief Operating Officer. So welcome, Donna, as well. And I also want to bring on and welcome Atul Grover, the inaugural Executive Director of the AAMC Research and Action Institute. The Institute convenes national experts to examine the most critical issues affecting the missions and institutions of academic medicine, develop policy and programmatic solutions, and harness member medical schools, teaching hospitals and academic health systems and academic societies to test, validate, and scale effective change. Hello, Atul. And I'm going to ask Sheila to get us started.
Thank you very much, Shri. I really appreciate the introduction. And let me say thanks to Ross, with whom I have a great pleasure to work with on a number of occasions, and to my friend and colleague Atul, who I've also known for some period of time. And we've had the opportunity to work on a variety of issues together. And certainly the issues facing this election are no different than the challenges we've seen before. While I cannot claim to be a Columbia graduate, I can in fact claim to be the proud mother of a Columbia graduate. My daughter got her master's in public health from Columbia, and is now a proud member of the Department of Public Health for the city of New York. So Columbia is well in the middle of all of the issues that we're confronting. So in today's discussion, I just want to give a couple of very brief opening comments. Healthcare has been a politically charged issue for more than a decade. We can look back to essentially each of the recent election cycles. The candidates for offices at all levels of government have talked about the failure of elements of our healthcare system and the rising costs. This election has to be absolutely no different than expanding access to care and reducing disparities, while Republicans said reducing the role of government, in fact, was their top priority. Notably, both parties rank healthcare costs as a high priority, particularly the cost of drugs and the treatment of surprise medical bills. So at least on that issue, they agree. But it's the method of addressing the cost issues and coverage issues where they differ tremendously. There is, in fact, a fundamental question about the role of government at the state level as well as at the federal level. The current public health care crisis highlights this question. What is, in fact, the role of government? Is it funding? Is it mandates regarding behavior? Is it research? Is it relaxing rules in some cases? Looking at the example of telehealth, for example, and its increased use of the waiver of rules regarding Medicare. So what in fact should that role be? And again, while our focus today in our discussion is really going to be on the federal level and the federal elections, anyone concerned about the future direction of healthcare in this country has to be alert to what is occurring at both the state level as well as at the federal level. One need look no further than the questions with respect to the expansion of Medicaid to realize that intersection is enormously important in terms of what the feds do, request, ask for, and how the states respond. And I guess the barriers that exist between states in terms of licensing, an issue that Atul and I have spoken about, and that is the barriers to practice. Issues around scope of practice all play out at the state level, but have federal implications as well. Questions of financing, the financing of education, specifically in terms of healthcare providers and how that is provided for and who in fact received those funds and for what. And the differences between the two candidates on each of these issues are as stark as it relates to those today, but clearly the role of involving yourself in these issues, the framing of those issues, in fact, experiencing in your own practice lives in some cases, how you in fact are confronting the healthcare system or your families or your colleagues and neighbors, and the framing of those solutions. Each of those are responsibilities that each of us may take on because the solutions and identifying the problems are best done by people who are involved at the main line of providing those services. So hopefully in our course of our conversation today, we can talk about how you can be involved and the importance of that involvement. And at the end of the day, the most critical thing is the remembering to vote. So we'll remind you of that, I suspect, throughout the course of our conversations. But thank you, Sri.
Thank you very much. And yes, ending on that note is so important. We're going to remind them multiple times to please go ahead and vote. Let's go to Dr. Lin.
Well, good afternoon, everybody. It's a pleasure to be here. And I think Sheila just, Atul and I don't need to talk because she presented such a comprehensive overview of some of the issues. But I'll add that, I'm on the ground here in Columbia. managing the faculty practice, working on a whole host of issues across the 4 schools with the dean and with many others here. And clearly the impact of COVID has to be part of our conversation as we go forward, because we not only had a crisis here in terms of the rapidity with which COVID hit this medical center and hit all of New Yorkers. And then the fallout that results has huge implications, as Sheila was saying, you know, in terms of our state government, our local government, and our federal government, because the economic impact was felt very strong and will continue to be felt strong here for years. And so part of the conversation about, you know, the election and the future has to be around other broad issues like Medicaid funding and the support for state and local governments that is being debated right now. Certainly the Affordable Care Act is on the table, and literally today in the Supreme Court hearings, the conversation around the support of the Affordable Care Act, which, you know, many believe, you know, created, while not universal access to care, at least eliminated that huge margin of 50 million people that we had uninsured back in 2012. New York has been a leader in expanding coverage, but we still have a significant uninsured population. And as you all well know, even when you have insurance in this country, you are often what we call underinsured. So the high cost of healthcare has led to many people avoiding getting healthcare services because they simply can't afford to begin to pay against their deductibles and their copays. So affordability is a huge issue across the entire country and in New York. New York happens to be, as a state, the cost of healthcare here is more than the national average. And so we have a number of issues to tackle. There are some other components of the Affordable Care Act that I think are under siege. Certainly the individual mandate, which has been challenged, even Medicaid expansion, although we've held it in New York. The national quality strategy, you would think it's not an unusual thing for a country to have a strategy around the other leg of cost and quality. But, you know, is that quality being worked towards by all in the system, or, as I think many of you know, is the quality of healthcare in the United States embarrassingly low compared to every OECD country and many countries outside of the OECD? So high cost, poor quality, inequity, as Sheila mentioned, you know, there is great quality on Park Avenue, and there's lots of places in New York City where there is no quality. Last thing I'll say, and I'm going to do this as a tee up for the tool, which is, you know, as an academic medical center, we have some unique challenges here as well around GME and funding and the higher cost of care that academic medical centers face. Whether you're a student who's in training, you're a faculty or a staff member, or you're just a citizen of New York, the continued support of academic medicine that is on the frontier of many new clinical discoveries, including in the COVID war, is going to be an important part of this conversation in the election and as well for the new Congress when they come in January. So with that, I'll turn it over to Atul.
Thanks, Donna. And I even have less to say now that Donna and Sheila have both spoken. But I will certainly identify with both of their comments and appreciate both of their leadership. I have not been a lieutenant governor. I have not. Sheila was actually referred to, I was watching Lawrence O'Donnell one night, and she's going to kill me for saying this, but he referred to her as the 101st senator, although I'm not sure she wants to be called senator given the behavior of some of our elected representatives these days. Nonetheless, you know, I think my representation here is really thinking both as a policy person, but as somebody who's in the provider community, not unlike Donna as an executive in one of our practice plans. So our physicians in hospitals are really nervous about anything related to healthcare reform that comes up at the national dialogue, in part because it is such a patchwork. And it's a patchwork in which We're underpaid in some areas. We're probably paid more than our cost in some areas because we're underpaid by government providers, Medicare, Medicaid. We have to figure out how to make that up from private payers who recognize that they can't leave places like Columbia Physicians or New York Presbyterian outside of their network. And that makes it a real challenge for us to figure out how any of these pieces fit together. Anytime somebody's talking about a $3 trillion healthcare system, they're not talking about wanting to spend more money. They're wanting to talk about spending less. And all of the ways that we fund education, research, discovery, community engagement is really off of any margin we can pull out of that clinical care arena. And in fact, that's why the faculty, in part, are working in a faculty practice plan in an academic medical center. They are willing to take a lower salary, in part because that funds some of the things like education and research. And then we have to take the rest from a clinical margin. So in an environment where everybody's talking about bringing down that revenue, that compromises not only potentially our ability to provide care to the underserved, whether they are medically or financially underserved, and also our ability to provide that cutting edge care that others in the community cannot or will not provide. So if you think about the level 1 trauma centers, the transplantation, but also some of the more run-of-the-mill things that really lose money for a health system like inpatient psychiatry or geriatrics, we're able to cross-subsidize a lot to be able to provide those services. And so if you look back to the ACA in 2010, we cobbled that together with the support of the bulk of the provider community. Hospitals in particular were willing to take, around about $150, $160 billion in cuts over 10 years based on the math of a Medicaid expansion, an individual mandate, the ability of the exchanges to work and to actually get paid a reasonable rate for these services. And so every little piece that's been cobbled away, whether that's the Supreme Court decision to not mandate Medicaid expansion, leaving 17 or 18 states that are outside of that realm right now, affected our ability for that math to work out and taking those cuts. And certainly now, as we look forward to potentially an ACA decision in the Supreme Court that could potentially strike down, only an individual mandate, or if it's not severable, strike down a lot of the things that even in a polarized world, people have come to value in what we call Title I of the ACA, which was keeping children of parents on their families' insurance policies till they're 26, making sure that there's coverage for people with pre-existing conditions, making sure that there's some maximums that people are paying for those rates. All of those things are potentially at risk, and that means the providers are potentially at risk. And so that math becomes even more difficult in a place like Columbia Physicians or in our teaching hospitals, because not only are we trying to put together the basics of providing healthcare to our community, but also these added missions of research and education and community engagement that otherwise might be lost. Now, the good news is people did agree on those individual provisions within the ACA. The bad news is we're still incredibly polarized. So the ACA polls better now than it did at any time since 2013 or 14, when most of the provisions actually kicked in. But if you talk to Democrats, 94% of them think that the ACA is a good program. Republicans, only about 11% do, right? So there's this huge gap there, yet they all agree on some of the pieces. For independents, the good news is 53% of them believe that the ACA is a good program. Now, the challenge is really, how do you get beyond a slogan like repeal and replace or Medicare for all and say, what are we really trying to do here? How do we achieve coverage for our individuals? How do we achieve quality when, in fact, I was thinking about, Donna, the comparisons that we make from the US to other Western developed nations, and we talk about shorter lifespans. Well, guess why our lifespan is becoming shorter? It's mostly in white men now who are dying deaths of despair from overdose and substance use and liver disease, right? Suicide. And these are real gaps in the public health system. So part of this means we have to figure out how we fund a public health system, not just for pandemics and preparation for crises like COVID, but also the basic wellness of our population. These are all challenges that haven't gone away since the ACA, and they're still polarized. Now, the good news, I think, as Sheila mentioned, as somebody who worked with Republicans for a long time, in my conversations with the people on the conservative end of the health policy spectrum, they are saying that there is a recognition like they have not seen before that disparities, health justice, inequities in our healthcare system really must be addressed, and there are systemic issues there. So I have some hope for being able to get some of these things done, but it's not going to be without a devil in the details. So I'll turn it back to you, Shri, and appreciate having the chance to have the conversation.
Thank you very much. I wanted to see if Sheila or Donna had a response to anything that they've heard from Atul. Otherwise, we'll go to the student questions.
I'm compelled. Again, I think both Donna and Atul have done a spectacular job of laying out some of the unique issues we face, both as a country and as a healthcare system. But I am compelled to note that the challenges that Atul so adroitly described, there's a unique set of issues for nursing as well. And I can't help but, as someone who is trained and practiced as a nurse, to indicate that as well as the issues around practice areas with respect to medicine, nursing similarly is facing challenges in terms of their practice environment and the challenges they're being facing and compelled to deal with, and the absence in some cases of support, but also the remarkable transition in how we are caring for patients. I mean, it's a hard thing to admit, but I couldn't have cared for in an ICU some of the patients we can care for now at home. And so we are asking of our healthcare providers, nurses, physicians, and others to face a very different reality, but the importance of team and the importance of the interdisciplinary relationships and the training opportunities in a interdisciplinary environment are even more important today than they were, in 1870 when I trained. But it's really how we as a community are confronting these issues. I think that has to be dealt with.
I'd add one thing, which, I think we're skirting around, not intentionally, but we expect something from our healthcare workers in this particular time that is extraordinary. And they are not at all immune from what almost all of us are feeling, right? We're feeling anxiety, whether it's about our healthcare, it's about our economy, it's about the uncertainty about the future, it's about politics, it's about racism. There is a lot of anxiety, anger, and concern about different points of view and the polarization. But our healthcare workers still have to respond, whether it was in the height of the pandemic, where learning on the job, as Sheila pointed out, was happening quite rapidly. And they were dealing with, many, many tragic situations. And so without, putting an exclamation point around at some point getting to mental health and support for our healthcare workers, I think is an important conversation as well, because we have extraordinary expectations for them. One of the concerns we have here is if there's a second wave, how do we ask people to go back into the line of fire without even more support than we've already been able to give to them?
Thank you for laying those issues out for us. And now I want to bring the students on, and a reminder to our audience, our virtual audience, to please ask questions. Use the Q&A format, or you can ask on YouTube, or you can tweet at me at Sree, S-R-E-E, and I can read the questions as well. So let's say hello to all the students, and then I will call on them one at a time to ask questions of the panelists. So let me tell you who's here. Spencer Dunleavy is here, Taivo Alonge, Charles Holt, Michelle Skelton, Nuran Hamadi, Tiaja Hunter, April Anchetta, and Mint Kwako Monded are all here. Students from each of the schools. There are two each from each school, and they will be asking questions. So let's go first to Spencer Dunleavy.
Hi, so my first question is, during COVID-19, health professionals have a unique position and perspective in a way that we really have not had before. So with 3 weeks remaining before the election, how do you suggest health professionals get involved in civic engagement?
Thank you. Atul, why don't we start with you, and then we can go to the others as well.
Well, as the other panelists said, the first thing is to vote. I think, if you look at the voting behavior of the American public, generally voting activity goes up with age and with educational attainment. Physicians are the exception. I don't know about nurses, but physicians are the exception. And I don't know whether it is we're too busy, or we think we're too important, or we think our vote doesn't matter, but you got to get out there and vote. And especially with those of you from all over the country who may be registered in different places, your vote's going to matter everywhere. I think, just on an ongoing basis, though, being informed, reading the newspaper, looking at materials that come out from interest groups, think tanks, Kaiser Health News, Axios, Politico, get on their mailing lists and read what you want to read, but stay informed and be an informed voter.
Thank you. Let's go to Sheila.
I think Atul has touched on the most important thing, which is informing yourself and becoming active and actually taking the time to vote. This is going to be a remarkably challenging time. I know I live in Virginia, and the lines are already hours long, and it takes enormous patience. But the importance, particularly of young people, it made a huge difference in past elections. And then you saw a period of time where essentially it dropped back to the more traditional voter, older, white, senior citizens who are the most active routinely. But young people made a difference in the past. We've seen it happen. And I think that's enormously important. And becoming informed, but also essentially helping those around you. There will be those who may be challenged to get to a voting opportunity, people who may be assistants in that respect. Talk with people within the school as to whether or not they're providing those assistance to people. But the most important thing is to start with yourself and with your friends and colleagues and recognize that it is a privilege to be able to vote in this country. And it's a privilege that, in fact, we often disdain. And again, remember that the elections at both the state and the federal level, I mean, there's not only the presidency that's involved this time around, it's also essentially the control of the Senate and the control of the House. So every member of the United States House of Representatives is up for re-election, and 33 members of the United States Senate. So you ought to be informed who are the folks in your area that are up. And look locally as well as at the federal level. Do you have a governor up? Do you have legislators? Because those decisions regarding healthcare take place at all of those levels.
Thank you. Donna, a thought from you?
Yeah, I think Sheila and Atul covered a lot. I do think the added piece is understanding, having your friends and family, hopefully if you've gone through some parts of the pandemic as a frontline healthcare worker, have them understand some of the critical issues that impacted you. I raised mental health, availability of PPE, use of other public health safety measures and where that's being supported and where it's not being supported. And I was lieutenant governor in another state that has a very complicated ballot. Not every state, and certainly New York, we're not voting for a senator. We do have the congressional seats, but in a lot of states, there are ballot initiatives that in fact very much influence public policy. And so states which are oftentimes, very active in healthcare issues can have ballot initiatives that you have to pay quite a bit of attention to. I know they're hard. Sometimes they're written in archaic kind of language. You don't know whether you're voting yes or no on an issue as you read the language. But pay attention to those and make sure, because the deadlines are still out there, that you can get, absentee ballots, or you can actually vote by mail. Because one thing at Columbia that we are not encouraging is travel, because it is a challenge for us as we bring people back from some of the hotspot states right now. Governor Cuomo has identified 36 states. So if you are a student and you live in any of those 36 states, you're going to have to undergo a mandatory 14-day quarantine that could impact, not only your life, but your ability to participate in some of your school activities. So not just vote, get your ballot early, and educate everybody about the complexity of the issues that you face as a potential healthcare worker and that your colleagues are facing.
Thank you. And it's so great to have these student questions so that we can pose them to the panelists. And a reminder to our attendees, our viewers, who are watching from all over the world, to please ask questions as well. We've set aside some time for you. Now let's go to the College of Dental Medicine. Michelle Skelton has a question.
Thank you so much. So my first question is also about COVID-19. Johns Hopkins data states that many places are reporting more COVID cases in the past 7 days than in the 7 days prior to that. Even if a vaccine is introduced soon, the next administration faces serious challenges. What does each presidential candidate believe in determining where the responsibility lies when it comes to public health measures? Is it on the state or the federal government? And how do these beliefs affect the ability to mitigate the pandemic as winter approaches?
Thank you. Who would like to go first?
I'll go first. I mean, I think, I'm going to try to strive for a general public policy position versus candidate X or candidate Y, because I think whether there's a national mandate or a state mandate, you need to enforce the mandate. And you need to create a culture of acceptance of the mandate. And for us, I know a lot of us, because I'm a DRPH person from Mailman, we try to use the words wearing a mask is about respect for other people. It's not about politics, and I really believe that. And I actually seek out some of my friends who in this time we avoid some of these conflicted conversations with people who've been longtime friends. But I've really decided to take the higher ground and say to them, you're in healthcare. These are the kinds of things that I know fundamentally are correct, regardless of issues around individual rights. One thing that's important to note is, I heard the expression used, and I think it's a great one, where we're fatigued with all of these measures. And so some injection of, it is important to wear your mask every single day, outside and inside, and some kind of, a cultural shift. And I've seen some, Chris Rock and some other, people who you might be more likely to follow than a president, a senator, or a rule that exists. So I think we've got to have a multi-pronged approach that isn't just about regulation, but is about making it part of who we are.
Thank you. Atul or?
Sure. I also will. I think the presidential candidates, Michelle, have been pretty clear about their beliefs and desires for the behavior of the American public. I don't think that there is necessarily a right or wrong answer to there should be a federal response or a state-by-state response, but it needs to be coordinated and it needs to be reported. It needs to be measured. We don't know how we're doing. And the fact that we haven't had the federal government really, Johns Hopkins is taking the lead here, right? And other private entities have taken the lead in terms of reporting statistics. Sheila was kind enough as a nurse interdisciplinary to work with us in our institute to release some face covering guidelines a couple of months ago. If you go to AAMC.org/COVID roadmap, you'll find all of our recommendations. But what was clear then and is clear now and is not political is that we ought to be wearing our masks, watching our distance, washing our hands, right? It's not that difficult. And I think the federal government said, look, we need to defer to the states and defer to the private market when it comes to testing and when it comes to mandating behavior guidelines. Fine. The conditions on the ground are always different. Everything is local. But the challenge was you had the federal government stepping in, and when institutions like Columbia or New York Pres or UCSF or Brigham and Women's were trying to procure things that our nation didn't have a national stockpile, N95s, gloves, gowns, and they procured them from China, State Department or Homeland Security or HHS was intervening and disrupting that flow. So we didn't even let the private sector behave as the way we wanted them to. We didn't let states do it. My governor in Maryland basically procured through the help of his wife, who's from South Korea, 500,000 or 250,000 tests. And again, he wanted to make sure that the federal government didn't find out where they were coming in. He didn't trust them. And even on something like testing, where we have some guidelines coming out the next week, I hope, from the Institute, you have to figure that now Rockefeller Foundation and the Duke Margolis Center and others have looked at testing and said, we need to be doing probably around 9 million tests at a minimum a day, right? 800,000 for diagnosis, another 8 million a day for screening. We have only done 110 million tests in the last 7 months. That's really what we need to be doing about every 2 weeks. Why? Because we left it up to the private sector, which is fine. And Abbott, the president said, great, there's 150 million tests coming from Abbott. Well, good. So we're good for 3 weeks. What about after that? And no one has stepped in to say, here's what we're going to do. I have a lot of respect for Admiral Giroir. He's a great guy, but he needs to be standing up there every day telling us where those tests are coming from, who's going to produce them, what DPA action is being used. It has to be coordinated. And I don't care where the leadership comes from. I think New York State has exhibited an incredible amount of leadership. I have a lot of respect for Governor Cuomo and for the institutions there because they did it the right way through a partnership. So there's no clear answer, but somebody's got to take the lead.
And
Thank you. Dr. Grover, could you just repeat the website? Because people want to make sure they have that
it's
information.
thank you for the plug, Shri. It's aamc.org/COVID roadmap.
And the doctor is on Twitter himself. He's Atul Grover, MD on Twitter. Go ahead, Sheila, please.
I was simply going to say I can't really add anything to what Donna and Atul have said, except to underscore Atul's point and Donna's, which is what was lacking was coordination. And there are responsibilities that play out in every single level, as Atul noted, whether it's the local level of the rules, whether it's at the federal or state level in terms of coordination of materials, the whole question of the stockpile. And going forward, I think one of the things is going to be, what did we learn from this example that we can apply going forward in terms of essentially whether it's resources, whether it's, and I'll tell you the next big challenge is going to be if we have a vaccine, one hopes, the whole question of distribution of the vaccine, how we prioritize the distribution, who receives it under what circumstances. That issue has arisen in remdesivir as well when it was first distributed. So the point that Atul makes, which is a coordinated indication of where the priorities are and decisions made that are consistent from federal to local, are absolutely going to be critical. There's already fear about, whether it'll be adequately distributed to whom and under what circumstances, but those are the kinds of questions governments have to solve.
Thank you. And folks, please keep sending your questions. We'll be doing audience questions in a bit. We're in the student panelist question time. Our next questioner is from the Mailman School of Public Health. Nuran Hamadi is going to ask a question.
Hi. So the United States is a global outlier on abortion within health policy, with 78% of high-income countries providing public funding for abortion. How can we ensure, beyond repealing the Hyde Amendment, that everyone with public and private health insurance will have abortion coverage?
Okay, who'd like to go first?
Well, I'll simply comment. You raised an enormously impactful question, but it is a question that if you've watched the hearings on the Supreme Court nominee over the last 3 days has been at the heart of many of the questions being asked, and that is the role of the court and essentially the lower courts and the decisions that have been made on a state-by-state basis. And what you're suggesting, the issue to be in terms of a decision as to the financing that is available, I think is going to be one that is going to require statutory change and ultimately will continue to go back through the courts. And this is another example of where it's fought out state by state by state in terms of limitations, in terms of funding, whether it's funding for Planned Parenthood, whether it's the state limitations on the period of time during which it's accessible. But I think the fundamental question that you're raising, which is the financing question, is the one that is going to have to go back through the Congress and be again debated, as it has been almost every year, certainly in the context of appropriations, both for local funding as well as our international participation.
Thank you. Who else would like to comment on that? Atul?
Look, I'm happy to offer that I think this is also going to be a state-by-state issue. I think you are seeing in the hearings over the last couple of days a divided Senate and a divided nation, often state dependent. I don't know what's going to happen even to the protections that are held right now through Roe v. Wade, but it may very well get turned back even more so to the states. I will say, though, that it's not as simple as Republican and Democrat. Even in the ACA, when we thought we had everything worked out on the Democratic caucus side, and there was a strong majority in the House and even 60 votes before Senator Kennedy died in the Senate, that was filibuster proof. You could not get agreement on things like abortion. It came down to abortion and geographic variation and payment among the Democrats. And so again, I will say this is where you vote your values and your policy interests. I don't care which side is right. I just care that you vote and you know where you stand on the issue.
Thank you. Dr. Lin?
I think I was going to say I have a one-word answer. It's vote.
That works. Okay, let's now go to the School of Nursing. April Anchetta has a question.
Hi, everyone. Thanks so much. As a bedside nurse in New York City, working at the peak of this pandemic, I know that this work will have lasting effects on the mental health of frontline workers, just like how all the panelists have already alluded to. From the trauma of having to deal with so much death and uncertainty at once to the lack of PPE and leadership, it's apparent that these experiences will take a toll. Further, just last week, the Kaiser Family Foundation released a report saying that mental illness may soon be the most common pre-existing condition in the United States. Can each of you speak to how a Biden and Trump administration would work to combat the impending mental health crisis Americans face, and maybe more specifically, how they would address covering pre-existing conditions?
Okay, let's start with Atul on this question.
So one of the challenges that we've had in the debate around healthcare is getting some clear facts from every side about where they stand on coverage of pre-existing conditions. ACA was pretty clear in establishing protections. Mr. Biden has come out and said that he wants to strengthen the ACA, so I think you can interpret that he wants to keep those. The president has said that he wants to protect people with pre-existing conditions, and yet he is party to the court case that will be up in November in front of the Supreme Court that could potentially strike down those protections as well as others. And so we have not seen from the Republicans that I am aware of legislation that would be in the replace form or a clear plan to do that. I think there's also some broader issues here around we in name only have mental health parity right now, but we do not have payment parity. And so there's a real lack of providers who are willing to see those folks. And it's one of the things I mentioned in terms of inpatient psychiatry that you can have at places like New York Pres or at Bellevue. These are institutions that want to fund this. And then the only other thing I'll mention to you is that the National Academy of Medicine has a collaborative right now on clinician well-being, and nam.edu, if you look for their resilience information. It's a huge issue in medicine. Our suicide rates are higher than for just about any other occupation. And our substance abuse rates are, our mental illness overall is, and yet there is so much stigma for us to talk about it. So part of this is a responsibility of ours as a profession to be willing to just talk about it, talk about people's issues with substance use disorders, talk about their issues with depression, with facing suicide ideation. Very few of us are comfortable talking about these things. And so we're working on that. The National Academies are, and I'll put the link in the box as well.
Thank you. Dr. Lin?
So I want to talk about pre-existing conditions just as a general topic, because I think you're going to find a lot of support on this panel for continuing, if not strengthening, the pre-existing condition requirement, because and many of us lived through, and I was an executive in a large health plan when that protection didn't exist. And of course, the disequilibrium in the market was huge. You could buy coverage, make no mistake about it. You could buy coverage. It just costs so much money. And usually states created these high risk pools. But the insurance companies engaged in a lot of bad behavior. In fact, when I went to Colorado as an executive at Kaiser, pregnancy was not a covered benefit in the individual market because you could exclude it. And so the fact, and Kaiser was the only health plan, and I maintained this position that we should not exclude pregnancy from coverage. It made no sense. But, you know, the health plans can play games with what they exclude you for when you don't have that pre-existing protection, whether it's for behavioral health issues or it's for asthma or for anything else that might have happened to you. On the subject of mental health, you know, Atul said we have a lack of providers, and I'd sort of stop the sentence and just say we don't have enough practitioners in the field to be able to take care of what this, you know, epidemic is. And at the same time, though, I think we need to de-emphasize the specialization in the field. One of the things that I did, again, in my time at Kaiser Permanente was to make behavioral health specialists the entry point to the system, not psychiatry. Because clearly many of the conditions that we're talking about now are not, you know, they're important, but they're not necessarily requiring medication intervention and the kind of intensive care. So we created a system whereby every single medical office had to have an embedded behavioral health professional who was free every half hour. And so that if you were delivering a diagnosis that was, you know, traumatic, or you as a primary care doctor could get a sense that there was something else going on in this patient's life, you could do a down the hall referral, which is really important because we often put, you know, not only stigma around getting mental health services, we put additional co-payments, we put barriers around go get an appointment and it's farther away. And so I think we've got to break down a number of barriers in the care delivery system, as well as in the financing system, as Atul said, around, you know, there's not parity in terms of really reimbursement. And we've got to step that up in terms of getting more people into the profession of behavioral health.
Thank you. And let's see if Sheila has a comment.
Just a couple of comments. I think I realize I look like I'm in a cave. I apologize. A couple of things. One, on pre-existing conditions, Atul's exactly right. There's clearly a statutory preference in terms of the ACA. There is no other, on the Republican side, there's been no alternative offered in terms of the specifics about how you would ensure that those issues were taken care of. There was an executive order by the president that had no standing in terms of legislation or legality. But this issue is going to be one that will be fought out in the context of the ACA. I would also note that in the context of insurance coverage and how it's constructed, and some of the issues Donna raises with plans that essentially provide very little real coverage. There's also a role here for the states, another case where it is both the federal government as well as the states that essentially oversee in many respects the regulation of insurance. So this is an issue, again, that plays out in a variety of ways, but it is an issue that will need essentially addressing. Should the ACA fall, there is no question there will have to be a statutory change that essentially requires that insurance companies this. The other issue, behavioral health, again, all the issues about the absence of providers, all the issues about the lack of real parity, notwithstanding the efforts by Senator Domenici and others to essentially pass the mental health parity legislation. The issue of how one integrates that into practice so that it's not simply a freestanding separate benefit, but how it becomes part of everyday consideration. I mean, the point that Donna makes about making sure there's somebody on the team in the environment that can essentially provide those services or those references. For many primary care physicians who are overwhelmed in their offices, you know, one more issue that they have to navigate, one more negotiation in terms of a partnership or someone in the community with whom they can partner to essentially treat those patients. So one of the issues that the bipartisan policy center is working on, which I've been involved in, is this question of integration. How do you make behavioral health part of the routine rather than a separate issue? But there is no question that there is an enormous need, particularly given the circumstances. And briefly going back to the issue of pre-existing, COVID will become a pre-existing condition. So that you essentially have, you know, millions of people that are potentially exposed, that essentially will now have a pre-existing condition. So how do we deal with that going forward? But both of these issues are enormously important.
May I ask a quick question to Sheila? What will happen if the Supreme Court, with or without a Justice Barrett, strikes down the ACA? What is the sequence of events? What will happen to the tens of millions of people who are now benefit from it?
Well, it's an interesting question. And it's one that I will give you some preliminary thoughts, but I think it's one that warrants some consideration. I think you have to assume that she will be confirmed. I think they will report her out, party line vote out of the Judiciary Committee, and McConnell will take her to the Senate floor. And I'm assuming it'll be largely a party line vote to pass her. It's a 51 vote. It's not a 60 vote. So essentially, my guess is even if they lose Susan Collins or if they lose Lisa Murkowski, they will still have sufficient votes to essentially get over in November. And if in fact it falls, then the question becomes what occurs on a state-by-state level in terms of what the states have done or what they have financed, and what the implications will be for both the coverage requirements as well as the financing that exists in terms of the subsidies to individuals to go through the exchanges. Some of the exchanges have been set up by the states. So there's operationally issues that the states have taken care of, but all of the issues around the underlying principles in terms of the coverage requirements, minimal coverage, things of that nature, will all essentially arguably be put aside and will have to come back in terms of being recreated if in fact that's the case. But Atul may have a point of view on that as well, as may Donna.
I think it's all a huge black box, beginning with is the provision around the individual mandate severable. Right. There are plenty of legislative solutions to this. If you talk to any of Sheila's current former colleagues, they'll say, yeah, we could whip up legislation for you easily. We could probably even get around the constitutionality of a mandate by making the penalty like $1, right? You could make it a non-intrusive penalty that would probably survive the court, but that requires legislative action. I don't know that that's going to happen unless the Democrats or whoever is in charge of the Senate come next year gets rid of the filibuster legislatively. I don't know that you can do it through reconciliation the way that Democrats had to end up doing this through the ACA. So it's really tough to see how you do this. And as Sheila said, you can't do this through executive order. That will not stand up.
Right.
Dr. Lin?
I was just reflecting, there are no winners in the repeal of the Affordable Care Act, not just because fundamentally I believe in it, but because unwinding that system is going to be horrific. And imagine if it's being unwound in the midst of another wave of COVID and people lose insurance. Or they don't, as Atul was saying, the individual exchanges which exist in different forms. There are some states like Colorado, quite frankly, New York, that didn't want to go with the federal solution, and they have their own exchanges which would stay intact. But the subsidies disappear, so the price of the insurance goes up. You might have plans drop out. You certainly will have hospitals lobbying extensively because they don't benefit from having more uninsured patients present themselves in their emergency room. So I think the healthcare industry as a whole will exert a tremendous amount of pressure. The health plans will lose members, the hospitals will have more uninsured, there'll be chaos, and patients, unfortunately, are stuck with a real dilemma.
And that's, of course, the problem that we worry about. Everyday people being affected badly by the machinations in Washington and elsewhere. We're now going to go to a second round of questions from our students. We have 4 more students from the 4 schools who will ask a question. We're going to try to move the questions and the answers along a little bit because we have lots of questions that the audience is also asking us. So let's go to Taiwo Alonge from VP&S. Your question, please.
Hello, everybody. My question is, medicine has a long-standing history of racism that's within its foundation and is prevalent today that makes racism rather than race primary determinant of disparities. Disparities such as, but not limited to, the overrepresentation of Black people with schizophrenia in psychiatric hospitals, Black women being 4 times more likely to die than white women during pregnancy, or the way we've seen COVID disproportionately affect communities of color. At this point, we have the data on racial disparities, and if we don't, you can unfortunately assume non-white patients will have worse outcomes than white patients. How does America begin to dismantle racism within institutions of medicine with policies, which we've, to my knowledge, haven't seen yet, in an effort to eliminate disparities and make healthcare more just and equitable?
I don't know if we have the capability of asking the dean to join us to answer that question, but I'll just point out that he's been leading a school-wide, CUIMC-wide, initiative to tackle a lot of these issues, including the training of more physicians who represent the people that they are serving, that are in leadership positions here at the medical school, that also deal with health equities and other kinds of issues. But I don't know if we have that technical capability, but I do know there is a substantial effort underway just here at CUIMC as well to tackle those issues, and a report forthcoming fairly soon. Can we do that, Sri? Do you know if the dean can join back?
I'm not sure if he's
All right,
here.
well,
There he is, Dean. There he is. Hi,
Okay.
Dean. How are you? Go ahead.
Thanks, Shri and Donna, and thanks, Taiwo, for your question. In early July, we formed a medical center-wide task force, and it has over 80 individuals, including students. And there were six working groups within that to cover themes of clinical care. This task force was around race and anti-racism, excuse me. And the 6 themes under those 6 working groups with broad representation, including students. Number 1, clinical care, inpatient, outpatient. Secondly, faculty recruitment, retention, and promotion. Thirdly, training and education and curricular change. Fourthly, community and public service programs. 5th, research in healthcare disparities and social justice. And 6th, civility and professionalism. And I think Columbia Medical Center, in partnership with New York Presbyterian, has made much progress over time, but gaps remain. And the first is to acknowledge those gaps. And the second is to take heed of the recommendations from this task force that are being vetted currently, that we hopefully will roll out in November or so. And the third part is probably the most critical part, is to have actionable items that are married to the recommendations, actionable items that are short-term and medium-term, and actionable items that are durable in nature, to make changes that are permanent and transformative. So your question is a great one, to which there's no easy solution, but it's something that we're not shying away from, that we want to address and we want to correct.
And Dean, will there be more opportunities for people to get involved from across the campus?
Absolutely. And so we want to, in essence, establish a report card, and have a subset of the people on this task force monitor how we're doing. Are we succeeding? If there are gaps that persist, what do we need to do? We want to be extremely transparent about everything. And our vision is to pivot all our local solutions and make sure, again, that they're durable and become a national leader in this discussion.
Shri,
thank you, Dean. Go ahead, Atul.
If I can quote somebody who was very thoughtful on this, who said, medical schools need to join with their students in dreaming of a more racially just and equitable America. That starts with dreaming of more racially just and equitable institutions of medicine. And that happened to be written by Taiwo. And if you go to AAMC News, you'll find his column, and I'll post a link to that. But I think that's the right place to start. For our institutions, the first work is really beginning to recognize that racism structurally and personally in our institutions and in ourselves, educating ourselves. And I will add that, you know, the president's executive order trying to eliminate funding for any entities that actually provide implicit bias training, anti-racism training is incredibly problematic. I'm sure it'll be challenged left and right, but that was a huge mistake on the part of the administration. We are trying to figure out how we as an organization, as AAMC, become anti-racist, more equitable. And with our institutions, one of the things that we have tried to work with them on is data and being able to, you know, Columbia and other medical schools have to report an incredible amount of data to their accrediting body, which we have an arm's length relationship with. A lot of that information can be fed back to the schools and put into dashboards. So we're really trying to figure out how we work with the academic medicine community to make sure that we are transparent and clear around hiring, promotion, salary policies, trying to work on Black men especially, but also the pipeline of people in medicine and research and science is critically important. And that's important not only in terms of taking care of populations who look like you and being cared for by a physician that looks like you, but also in terms of forming a research agenda that makes sense for those populations that are most affected by those disparities and health inequities. So again, I'll put some links up if I can post them in the chat to some of our resources, but part of it is just recognizing it, trying to educate ourselves, doing the implicit bias training, and identifying those racist structures within medicine. And we're going to continue to do that regardless of what executive order is out there.
Thank you very much. I see a question along the same lines from Vaughn Hunter on YouTube. So I encourage everybody to go and look at the links that have been shared by Dr. Grover. I should also point out today would have been the 47th birthday of George Floyd, and he leaves an incredible legacy. It's such tragic circumstances. If there's anything that positive that has happened is the awakening that's happened in America. How long it'll last and how deep it goes remains to be seen. We have many more questions to go through, so let's now go to the College of Dental Medicine, and Charles Holt has a question.
Actually, Sri, if I could just briefly interject. One of the things, I think nursing schools are doing very similar kinds of analysis that Atul notes. And I think, you know, the story that we all tell and we believe that it doesn't count unless it's counted. And I think the data collection, the analysis that tells us what's really taking place, which is beginning to put a spotlight on what in fact has occurred in terms of care, distribution of services. But Lauren Underwood, who's a congresswoman, has been very active, particularly around maternal mortality among Black women. And Lauren has led the caucus that essentially has looked and put together a whole series of bills called the Momnibus that addresses a whole series of issues with respect to maternal child health and maternal mortality. She is a nurse by training, one of the few nurses in the House, but it's worth taking a look at what Lauren has done and what some of the work is that she's looking to in terms of trying to inform broadly the financing of services, the structure of Medicaid, and so forth.
Thank you very much, Sheila. Let's go to Charles Holt from this College of Dental Medicine.
Yes, thank you. According to a survey by the American Dental Education Association, the average dental student debt among class of 2019 graduates was $292,000. The cost of undergraduate and graduate school remains a barrier for many Americans and a burden to those who carry the subsequent debt. And I'm afraid because this debt could cause more providers to incorporate less Medicaid patients, causing less access to care for those that need it the most. And this issue has only been exacerbated by COVID-19. With that in mind, what are the candidates proposing to alleviate student debt burden?
Thank you for that question. Who has a thought on that and can give us some information?
I'll give you at least a thought on it. And again, I'll find a link to put up there. The AAMC, because students, medical students and pre-health students are part of our institutions and part of our governance, And Charles, in fact, we have a building, Sheila knows, down the street from her, that we actually live in the same building with ADIA and with the PA Education Association and with the colleges of nursing. So we're trying to work together on some of these issues. One of the real salient issues around student debt is public service loan forgiveness. And so when the rules were changed a couple of years ago, it's probably a decade ago now, around income-based loan repayment, that was a good start. I think it's a good mechanism to help with people that have extended training and educational periods like health professionals. But I will say that administrations of both parties have tried to eliminate the graduate provisions of the public service loan forgiveness program, which means that beyond $55,000 in debt, kind of on your own. So Congress thankfully has enabled us to keep those provisions around. But that's something that I do not know the candidate specific positions, but I know that when the former vice president was in the Obama administration, they also proposed to cut back on public service loan forgiveness. And I'll make a plug for serving as a health professional in one of our academic medical centers, in our not-for-profit hospitals, clinics, FQHCs, because after you dedicate 10 years or so of your time, you can get your loans forgiven under the current guidelines, right? So it's really important that we advocate to keep those for health professional students along the way. So I'll put in a link to that as well.
Thank you. Dr. Lin, a thought from your side?
Yeah, I mean, I think Atul addressed the issue well. I'd point out one other thing that's connected, which is workforce planning. One of the things none of us touched on because we were trying to be concise in the introduction was, the looming provider shortage that we have coming, whether it's in primary care, it's in dentistry, it's in many aspects of medicine, and it's particularly acute in rural areas or in serving populations that don't have traditional commercial insurance. So, I think in addition to having the conversation around how do we support students who are training for those professions, we need something that you would think would be common sense, which is an identification of what are the needs in the future. How do we structure graduate medical education so that it helps support us getting people into the specialty areas that we need. I mean, I think many of you know we have an oversupply of some specialties that is driven oftentimes by the amount of money that can be made in those specialties, and an undersupply in some other critical areas. And I often like to say, having had some dental practices as part of the delivery systems I've worked in, the mouth is in the body. Therefore, we need to have a comprehensive view. Not that dentistry is so separate from medicine.
Thank you. Sheila, a thought?
Just briefly, building on the comments, there's a long-standing question as to the role of the programs that are traditionally found in HRSA. And they are programs, as Atul described, that essentially create an expectation of return of the loans if in fact you essentially have worked in areas that are underserved. The future of those programs is one that under a Trump administration is called into question. They essentially consolidate or propose consolidating a number of them. The presence of the National Health Service Corps, some of the other graduate loan programs have been essentially reduced in budget over time. They have been looked at as to whether or not that is the right tool to essentially get people into areas and to retain them in those areas. And my expectation is that under a Biden administration, there will be a great deal of attention paid to what the right financing and incentives are for essentially encouraging people to go into this training. And this goes back to the earlier point about making sure that our delivery system looks like the patients we're serving. So how do you incentivize, how do you support, how do you get individuals out of certain communities that have been traditionally present in medicine and nursing, and how do you get them into schools? How do you support that? What is it that we need, to Donna's point, going forward? What are we looking at in terms of the needs across the health professions, and what are the right tools. I mean, we have graduate medical education that's financed in a certain function under the Medicare program. The bulk of the money, however, that is not Medicare related comes out of HRSA. Questions about supportive community colleges as ladders to get people into four-year universities and into health professions training. So I suspect that under a new administration, you'll see a wholesale review of those exact issues. And under the Obama or under the Trump administration, I think there has been a reluctance and there's been a reduction in the financing of those programs, and a real question as to whether or not they are in fact serving the needs of the population in terms of encouraging people to go into those areas. So I think very different visions in terms of the role of the federal government in incentivizing people to essentially choose those areas of practice and going into those geographic areas as well.
Thank you, and thanks to Atul for posting all these great links in there. Let's go back to the Mailman School of Public Health. Tiesha Hunter has a question.
Hi. In an AMA panel, pediatrician and California Children's Trust Director, Rhea Boyd, said 1 in every 2,000 African Americans have died of COVID, and we have to watch Ahmaud Arbery get lynched and George Floyd get publicly executed. The past few months have highlighted that police brutality is a public health issue. With Biden's tough on crime pass and Trump's support of racist rhetoric and organizations, which candidate do you believe is best prepared to combat systemic factors that contribute to health disparities experienced by Black communities, and why?
Thank you for that question. We'll go to our team for thoughts on that. Atul or Sheila, do you have a, yeah, go ahead, Sheila, please.
I think it is, I think it is a fair question to ask. And I think the answer will depend on where you stand. I think there are those who believe that ultimately a Biden administration will more directly deal with or address the issues. The question of the role of community policing, the support. There's nothing that he said that really suggests funding the police, but the question is how do you equip the police to essentially be more responsive to a community, whether it's having someone in the police task force that are involved in managing situations so that you don't have the kind of return in crisis that you've seen. So I think the Biden administration would likely confront it in that fashion. From the Trump administration standpoint, I think they've taken a much harder sort of law and order, sort of fund the sort of military side of that question, and in fact at times have brought the military to bear in terms of domestic situations. So I think there is a stark difference between the two in terms of how they would address it. And I think you would have to look to those approaches to make a decision as to which of them you are most comfortable with. I mean, there's a pattern of behavior here, and I think that you have to look at what has gone before.
Thank you.
You know, I'd add, I spent 20 years in New York City government and 3 years in state government. And we never looked to the federal government for help. It just isn't the way that policing is funded. It might be important from a tone perspective in terms of, you know, creating a lot of the, you know, dampening a lot of the noise and the inflammatory rhetoric that's going on. But when it comes to both funding, operations, you know, it's done at the local level. And I think that, you know, being active in sharing your voice at the local level is in fact even more important. So we have a mayoral election coming up. I know there was a forum today or yesterday that there was a big conversation around the current police commissioner and some other actions that you know, have been of great concern. But I would suggest that yes, we want to tone down a lot of the rhetoric and the divisiveness, but focus on how you can get more engaged and have a greater voice here in New York or wherever it is that you're residing.
Thank you. Let's go to our final student panel questioner. It's Mint Kwakamonded from School of Nursing. Your question, please.
Hello, thank you. I'd like to hear from all the speakers what you think about the feasibility of enacting Biden's public option plan in his healthcare proposal.
Great. Atul, you want to start us off?
Sure, I'll start. It's been the topic of much conversation around the building or the virtual building these days. And, you know, a lot of this, as I mentioned in my opening remarks, comes down to the details of payment. And so the public option in it of itself, if I talk to health system leaders, talk to Dean Rustke and talk to Donna, everybody wants as close to universal coverage as we can get. The devil's in the details of the payment. How do we make the math work? And so the public option is likely to pay us, you know, not as well as the private payer, hopefully not as poorly as Medicaid in some states or Medicare overall, so that we're losing money on every patient. But the real, I think even understanding that there may be limits to, you know, hopefully we won't be losing money on the public option payment. The real sticky detail is going to be, you don't want to lose people from the employer sponsored insurance base and allow them to go into the public option. What Vice President Biden has said is that, as I understand it, the public option would largely be automatic enrollment for citizens of states who don't expand Medicaid, so that they can get some kind of coverage without, you know, essentially forcing the states or incentivizing them with a huge pool of money to expand Medicaid. So I think it's something that, you know, the providers right now, if you listen to them say, heck no, we don't want it. I think there's a needle to thread there. It can be done. I think there have to be very clear safeguards and some other protections. But, you know, I'm curious as to what Donna would say from, you know, like a practice plan perspective, like how much would you really worry about that?
Worry quite a bit. And it's not to say that we can't be supportive of the overall, the arching view of, you know, as I said, universal coverage. I don't think you'll find people in the health policy space that are going to debate that too much, because we know that if you don't have coverage, you don't get care. And care is essential for preventing the acceleration of many illnesses. So, but yes, the dynamic that's happened since the passage of Medicare and Medicaid is that the bigger that market expands, the more leverage the federal government has over reimbursement, and often makes decisions that aren't exactly logical. They're driven sometimes by politics. It's really hard to understand some of the rationale around the Medicare schedule. Actually, I shouldn't do that because Sheila, I know, has been very involved in a lot of those decisions over time. But, you know, I think we stated early on, some procedures are overcompensated and some are undercompensated or undervalued. And that whole redistribution is important, but it can't be a net negative, because you know, the practices are built around an infrastructure and staff, and you know, we're already struggling with. We can see it now, the increase in the number of Medicaid patients, which is a direct result of unemployment, is creating challenges for the practices in terms of being able to see all the patients that they want to see, but to be able to have the revenue that allows them to do the work that they need to do. So public option, in our hearts, I think, and in our minds, yes, we're very worried about the kinds of controls and restrictions there would be on reimbursement.
Something else that—
Thank you, let's go.
I just wanted to throw in, you know, one of the challenges we have, if you look at providers, they're also skeptical because, in a sense, you know, for Donna to admit, to say, well, you know, we're probably overpaid in some places, is incredibly dangerous in Washington, right? Because what they'll say is, oh, well, let's take care of that first. And we say, but we're underpaid in these 20 other things. Oh, yeah, we're going to take this extra money first. And we promise we'll come back and figure out how to pay you more for those services. And it never happens, which is why you've got to figure out how to do something either really big or really small.
Sheila, your thoughts?
Well, let me just talk about the politics of this. I think the direct answer to your question, or what are the chances, it'll depend on what the status is of the Senate. Essentially, if you don't flip the White House the Senate isn't going to happen. If in fact you were to flip both the White House and the Senate, then you get to all the questions that Atul has raised, which in the broad scope, everybody believes in essentially increasing access. Everybody believes in increasing coverage. But when it comes down to the details about what the financing structure is, what the choices are that people make, what the structure of the benefit would look like. We've gone away from you saying Medicare for all, because that's not really what people intended, but it's the details of how you would structure such a system, how it would vary. We know there's enormous variation now in the plans that are offered. I mean, there's basics, but then there's all these variations. We know that there are an increasing number of states, thank heavens, that have chosen to expand Medicaid, who have picked up a lot of those singles and childless couples who were the folks that were left out before the expansion. But in fact, we end up with a different administration and a different Senate. I think then the challenge will be, what are we willing to agree to in terms of the rules of the road? And to Atul's point, how you pay and who you pay and where you put the benefits will make an enormous difference. And that's where it becomes very complicated. What's the value of certain services? Do you use Medicare payment rates? Well, that's not going to make many people happy. You certainly don't want to use Medicaid, which tends to be far lower, but do you want to use commercial rates, which tend to be much higher? And what's the financing? Is the financing general revenues? Is the financing a payroll tax? So, once we get beyond the great idea, then comes the tough part, the drafting, and what it is that you want to see. But before all that happens, you've got to change the White House and you've got to change the Senate.
Thank you. We only have a few minutes left, and we have several questions that have come in from the audience. First, I want to thank our students for doing such a great job with their questions. They were such a great range and in-depth questions that really helped illuminate the issues we're trying to tackle today. So thank you very much, students. Let's now go to some of these questions that have come in. Romeo is asking, there was an astronomical failure with who takes the lead in public health crisis during COVID. Is there any chatter or movements in reforming what will happen for government reforms in a future time or the next pandemic? Because we're certainly going to see this again. Who'd like to answer that?
I think just, I'm going to give this to you just as an observer, right? Because I'm involved in the direct delivery of care, but as an observer, I think Columbia and New York Presbyterian were fortunate because when we talked about some of the PPE shortages, while we experienced it initially, there were a lot of connections that we were able to rely upon. In fact, we have a surplus of PPE that we then started donating back to the Greater New York Hospital Association because they were performing that intermediary role. I think government didn't know what was coming at them. And certainly at the national level, I guess the biggest disappointment that's well publicized is that the CDC, which we all sort of grew up as health policy people, revering and respecting their data, their leaders, has been in a very different role. This is a public health issue. There's a leadership component to it, but strong public health leadership at the federal level is essential in my view. I think you also, Governor Cuomo took on this role with not a public health person, surrounded by some great public health advisors. And, even though there are people who say, well, if only this had happened 1 week before, this would have been an outcome. I have to give the state kudos for part of being a leader is being willing to put yourself out there and make tough decisions and not worry about the criticisms. And I think that the governor did that and didn't play politics, and hence New York, went from being in a crisis situation to really being a success story. And he means business, and I think we all know that. And the degree of compliance here in New York, and also the focus on data and science-driven decisions is something I wish was replicated all over the country, if not by the federal government and 49 other states.
Well, let's knock wood and cross our fingers that we stay as good as we have. We have so many questions coming in that we won't get to each panelist for each of the questions, but we'll also give each panelist a final thought where they can incorporate some of these questions. Do you think drug pricing transparency will help taper costs down? There's a question from Giannis. Does anyone have a thought on that?
Well, it's hard to imagine that transparency, absent anything else, will deal with the fundamental questions. I think there will be issues about who negotiates the prices. The whole question that goes back to issues around patents and the length of patents and the rules in terms of entry, the competition between generics. I think transparency is one part of a much bigger set of questions. And I think we've seen some of that play out. And again, you've seen, this question of whether the listing the prices, people will make choices. People make choices in most cases with respect to pharmaceuticals based on what their providers tell them, rather than simply going down and saying, well, I only want this one. It has an impact, but there's a much broader question about how you bring much more competition into that market, I think.
And I think the evidence is that even when there's data, people don't always use it. Or there's other barriers and limits to use
the next Sure. The next question is actually for Dr. Grover, so he can answer that last question and this together. Dr. Grover mentioned the disconnect between state, federal, and private industry responses to the pandemic. And we saw what happened at Elmhurst Hospital, for example. In the light of the successful responses from countries with centralized emergency decision-making, such as South Korea and New Zealand, what can we learn from that? And this is an echo of a previous. So, Dr. Grover?
Okay, and I'm hoping you can hear me here. I had a problem with my audio for a second. I think, just back to the other question about the drug transparency, I agree that just being transparent about prices is going to be tough. What Sheila mentioned about, people pay attention to what their prescriber, their provider gives them in terms of a prescription or a recommendation. I think, we're trying to get information, and this is where all of my IT friends out there working on interoperability and information systems, what we really need is real point of care information about the drugs that we're prescribing, to take all these public sources and let us know as providers how much the patient's out-of-pocket cost is going to be. We don't know most of the time. I think University of Utah, other health systems have done a great job of trying to get this information out there, but it's tough for us even as providers to factor that stuff in unless it's easy to access. In terms of centralization of decision-making, we are a decentralized country, and the states have an immense amount of control that they hold unless, we basically say that the federal government has control over something. Now, the feds do have money in many cases, and that's the way you can make these things happen. And I think what Donna mentioned about, Governor Cuomo's partnership with the Greater New York Hospital Association, my colleague Ken Rasky at Greater New York is an amazing force, and I love seeing him up there some days in press conferences with Governor Cuomo, because it really showed that collaboration between the private and public sector. And I think what the federal government can do through the Assistant Secretary for Preparedness and Response, ASPR, through HHS, DHS, and even Department of State and the military is try and figure out how they make sure that the supply lines are available to people, that the information is fed back to them, right? The hospitals have been challenged, and whether you're complaining about whether it's the CDC collecting the information or HHS or ASPR, somebody's got to do it, and it's got to be done in a way that makes it easy for people to report and fed back to us. We can't fly blind, so we need the information back the way that Governor Cuomo and Greater New York Hospital Association function together. So I think the biggest thing the federal government can do, because we're not a centralized power in terms of federal structures, is to actually put money behind it, put supplies behind it, and be a broker of information.
Thank you. Stephanie has a great question about nurses. How do you think the future administrations will address the barriers we still have as nurses, as Sheila Burke mentioned? In other words, how do we make sure we have a seat at the table?
Well, of course, my general reaction to that is you take it. You make sure that every
take the seat at the table. So get involved.
Absolutely. Don't wait to be asked. You know, every committee, every discussion ought to have nursing involved. We are critically involved in the delivery of services, both inpatient as well as outpatient. We are critical part of the team. And I think an incoming administration, we just had a new appointment to the head of the National Institutes of Nursing Research, has just joined the team at NIH. We've talked with her about the importance of highlighting involving nurses in research, not only within that institute, but across the institute generally. Certainly within every clinical facility and every program, whether it's Donna's work or, and I know Tool has worked within his group in the interdisciplinary discussions that are taking place, but nursing needs to be at the table. And I think in part that's nursing essentially asserting the role that they are playing in terms of these questions and decisions about care, about caring for patients, but also the challenges they're facing. And I think there's just no excuse for that not to be the case.
I think the other thing, Shri, is that, you know, if you look at what are the inhibitors.
And I know certainly there's.
Oh, sorry.
Go ahead, Atul.
No,
go ahead.
One of the inhibitors of that collaboration is the payment system. And so if you've got an integrated delivery system where payments coming in a way that you can make this not as scary for the physicians who want to be at top of the food chain, right? If you're at Kaiser like Donna, or you know you're at a big academic center, what Donna was mentioning about the ability to have in your clinic behavioral health, a social worker, an LPN, an LVN, a nurse practitioner, a PA, a clinical pharmacist that all get paid in for the most part on salary, that it's a lot easier for me as a general internist to turn over and say, you know what, I pretty much suck at telling you how to use an inhaler. Go down and talk to the clinical pharmacist. I don't know what to do about this social issue problem. Please go talk to the social worker. Let me walk you down there so you can talk to her. And I think physicians have to, and this is where the educators come in, we have to turn out this next generation and further generations of physicians who don't demand to be in charge, because sometimes they ought not to be in charge. And sometimes the nurses can do it better and the social workers can do it better. And we just have to be willing to admit that payment not being threatening is a huge key to that.
Well, and payment matters. I mean, the Medicare, the Payment Commission, in fact, have recommended that nurses bill directly, that they not essentially bill incident to the physician with whom they're working, exactly to Atul's point. So we identify who's providing the service, and they are essentially part of that team. And there's no question that financing is a huge part of this.
Thank you. We've just
it's just a recurring theme. I'm just going to say, you know, a lot of the decision making around what nurses can do is done at the state level, and being able to influence the state legislature, the medical examiner board, you know, or all the licensure agency is really important. And quite frankly, you know, another thing, Columbia was a pioneer and was getting nurse practitioners to be able to practice and to get paid equivalent to primary care doctors. That happened right here at the School of Nursing at Columbia.
Right. Well, and
Thank
Bobby
you.
Berkowitz did a huge amount of that.
Thank you so much. We just have enough time for a final thought. No problem. We only have enough time for a final thought from each of our panelists. So what I'm going to do is read a couple of comments and a couple of questions, and feel free to incorporate them in your final thoughts. I'll go to each of you in just a minute. Linda says, interesting discussion. Shannon says, thank you for hosting this event. Ibrahim says, I love Columbia University. So that's a great comment from one of our viewers. Some of the questions that have come in: can you expand more on police brutality as a public health issue? Do you think there are reasons to be concerned about the long-term security and use of personal health information by healthcare providers? And also a question about addressing rising healthcare costs that have made it so unaffordable for so many people. So I know I threw a lot of things in there, but if you could address some or all of those in your final thoughts, that would be great. We'll start with Atul.
What a great honor to be with the panelists and with you, Shri. I really appreciate it. I think, you know, these are, for those of you interested in health policy as a career, the good news is you got an endless supply of issues to work on. We will never get it perfectly right. And that's despite, you know, Sheila and Donna and I and others being at it for a long time. When it comes to things like personal information, again, put this in perspective, in the 1990s, when we barely had an internet, right? People were worried about this proposal that the Clintons had about having a card with information on it. What if you lose the card? Every other week, I get something from a bank or the VA or the federal government that was my employer saying, hey, we lost your social security number again. Hey, somebody tried to file a tax return in your name. I mean, this is an IT thing that I think is the horse is out of the barn, and people can find out. Facebook has the algorithms to know which diseases half of us have anyway. So I think that, we put those structures in place. The benefit we get out of that information is going to be better than anything. Addressing costs, addressing coverage. I think the challenge is for all of us as informed citizenry, as voters, as participants in the process, to really force people to talk about what they're going to do to fix the problem. Tell me about cost. Well, what does cost mean to you? Is it cost to the system? Is it cost to each transaction? Is it cost out of pocket for me? All these things have different answers, and they're all quite different in how people approach them. So I think we have to get to coverage as coverage, but coverage for whom, and who is going to pay for it, and what is it worth to us? And we also have to have a broader conversation in this country beyond, even the stuff about policing and race. It gets back to healthcare issues, because people still have this sense of 1980s and Ronald Reagan and the welfare queens, right? That somebody's getting something for free. But if I ask you in general, do you want everybody around you that you know to have healthcare? Absolutely, but not that person, right? We have to have these discussions, and so I think we have to get to the individual problems. We have to have a conversation about what we're seeing as great strife and conflict in our society right now, our own inherent racism and biases, and that of the system. So that's all tied together to me.
Thank you. Dr. Atul Grover is inaugural executive director of the AAMC Research and Action Institute. Lots of virtual applause for you, Atul. Thank you very much. Let's now go to Sheila Burke.
Let me reflect on both the quality of the questions asked by the students. I think they've done just a remarkable job, and I think have highlighted a number of the areas which you summarized, Sri, in your remarks that we need to address. I think at the heart of it, the issue around transparency, it was raised in the context of drugs, but it's really the broader question, and it touches on the issues that Atul raised, which is the need to demand answers to the questions being asked. And details about how they would deal with those problems. Certainly issues with respect to racism, which is in fact a public health issue. It's a broad set of issues. We've for too long allowed people to skate by, not answering those questions and giving us general terms. But in fact, the demand for answers to those questions, the demand to being at the table, I think are absolutely critical. I think healthcare providers have a unique perspective because, in fact, you are confronting and dealing with patients and with the community in a variety of ways. And I think you're in a position to frankly defend them and to defend the services that they need. And these questions about who and the what, I mean, Atul reflected back on the Reagan administration days where I was on the Senate staff at the time, and we went through a whole series of measures that were fondly known as COBRA, OBRA, TEFRA, DEFRA. They were all legitimate sort of efforts at budget reform, but with a fundamental difference of opinion as to what the role of government should be. And the questions that were asked at the time, to Atul's point, is absolutely we want people taken care of. Absolutely, we essentially believe in nutrition benefits. But are you prepared to pay for it? Became the struggling question. And the answer was, well, no, that's not my responsibility, that's somebody else's. So I think exposing those underlying questions, that it is all of our responsibilities and it is part of the fabric of who we are as a country, I think is going to be critical. And I think it begins with your asking those questions. I went to so many town hall meetings when I was on the Senate staff. And I will tell you that I would be in a town hall meeting in Osawatomie, Kansas. And everybody you could imagine, the local teacher would stand up, often the local physician would stand up. I never heard a nurse stand up and say, I'm a nurse, and these are the questions and these are the problems that I'm confronting and that my patients are confronting. There ought to be no town hall meeting, no meeting held in which those questions are not asked. of the people that are running for office, the people that are coming to do their local activities, whether it's your local alderman or whether it's your congressional representative. You must begin by asking those questions and asking them and demanding of them those answers. And it begins with voting. It begins in identifying candidates who support the issues that you're concerned about. And it's being available to answer the questions and putting a very personal public face on the questions you're asking. It's not something vague. It's, you know, the mother, the sister, the brother, whomever it is. And that's how you begin to drive toward the answers to those questions. If you watch these Supreme Court hearings, the number of stories that were told and the number of faces of individuals who were directly impacted are a critical part of that process. And that's part of the role that we all have, is being that public face and demanding answers to those questions.
Thank you very much, Sheila Burke, Senior Policy Sheila Burke, Senior Public Policy Advisor at Baker Donaldson and former nurse herself. Thank you for your comments, and big virtual applause to you. I should also point out that school nurses and their value has become also something that's in the spotlight in this season, which wasn't the case before. So we are grateful for one aspect of this is people are appreciating what school nurses are doing. Let's go to Donna Lynn. Dr. Lynn, to you.
Great, Shri, thank you. And again, thanks to everybody who was involved in organizing the forum. I have to confess, my day is nothing like what we've just gone through. This is exciting, it's stimulating. Oftentimes we're worrying about, you know, construction costs or issues around paying bills. And this has been great to be able to think a little bit outside of the box and think about broad policy issues as we head into a very important election. You know, children can't do well in school if they don't have good health care and good dental care. People can't go to work and be productive and contribute and feel valued if they're not healthy and if they're not getting mental health benefits. So I think we have a responsibility to our younger generation and to each other to make sure that we provide access to the kinds of coverage that they need. This is not an entitlement. And unfortunately, I think the history of the United States has been very different, that healthcare should be a basic right. And that's what will make the society strong and grow. I do want to comment about the PHI piece and, you know, and data, because, you know, as Atul was talking, I had the benefit of working in a very integrated delivery system for over 10 years of my career. And I saw the value of being able to have for our physicians, for our occupational therapists, for nurses, for people in the call center. I was happy to have them have every bit of information they needed to help manage my healthcare, because they reminded me of things to do, whether it was to get a mammogram. They were vigilant about my medication compliance. You know, the system that was devised, that was very integrated, and that the data was all interoperable, really helped manage my care. The truth is, and I do a lot of work in the HIPAA area, and we watch our compliance with PHI here at Columbia. The hacks that occur across almost every health system or insurer, it's all about getting people's social security numbers so that they can do nefarious things. No one's really looking for your healthcare information. And I know that was an early fear back on, that somehow employers would get their hands on something about you as an employee and discriminate against you. That is really not the kind of hacking, or even it's I'm going to steal a device, not for the information in the device, but for the device itself. So I just sum it up and say we have a lot of work to do. The challenges are numerous. The students' questions reflect that they're energized and engaged. And obviously, because they're students here, they made a decision to pursue a path. And I think we're really hopeful that we can continue to support them and build for them a good career and hopefully some needed change in healthcare, which is ossified. And I think we all envy many other countries that are doing it better than we are.
Thank you very much. Dr. Donna Lynn is Chief Operating Officer of CUIMC and the CEO of Columbia Doctors and former Lieutenant Governor of Colorado. Thank you very much, and virtual applause, lots of virtual applause to you. Let's now hear from Dean Ruskey.
Well, thank you, Shri and Ross. Really appreciate Shri. You did a masterful job of being the conductor. And to our panelists, I learned a lot this evening, and especially to our students for leading the questions, and to all the other students. We had a great turnout at its peak. So this was really informative. It's inspirational. And I think these discussions are extremely important to help provide a North Star for us. And as everyone has indicated, please do vote. That's really important for civic responsibility. Thank you again, Shri.
Thank you, Dean, and thank you for your leadership. And to all the panelists, thank you very much. Doing this every 4 years is an honor and a highlight for me. Thank you very much. Everyone, please vote. And let's go back to Ross, who's, I may be the conductor, but he's the mastermind of this whole thing. So over to you, Ross.
Well, thank you, Sri, and thank you to Donna, Atul, and Sheila. It really was fascinating, and really, we think we all learned a lot. Special thank you to our wonderful students, Spencer, Tiaja, Mint, Michelle, Charles, April, Naran, and Taiwo, who did a great job, posing some really probative, interesting questions of our panelists. Thank you to Dr. Grodman for your support. Thank you to Dean and Neil Dean Ruskey for joining us tonight. Special thank you to all the members of the staff who were involved in this program, making it happen. Staff of the Government Office of Government and Community Affairs at CUIMC, staff down at the Communications Office down at Morningside, and some really sort of last second pinch hitting by the CUIMC Office of Special Events really helped out here tonight. As everybody has mentioned, the election is now less than 3 weeks away, and I encourage everybody to make a plan to vote, whether it be in person, early, or by mail. Regardless of how you plan to do it, it is crucial that everybody gets out and votes on or before November 3rd. I hope you found tonight's CUIMC Election Forum interesting and educational. A recording of this event will be available on YouTube and other social media platforms, so please let colleagues, friends, families, and others know that they can still watch tonight's event even if they did not see it live. Again, I'm Ross Fromer. Thank you for joining us. Do not forget to maintain social distance, wash your hands, wear a mask, and of course, get your flu shot. Stay safe. Good night.